Hi there, everybody. We're just going to let everybody just join in and we'll get started in about 10 seconds or so. Perfect. So we've got a good couple of hundred in now, so we'll get started. So thank you, everybody, for joining us again. We've got another fully booked webinar, which is fantastic. Before we start the session, just a couple of housekeeping notes. We've got the Q&A box and we'll be doing the Q&A at the end of the session again. Please pop your questions in the Q&A box, not the chat box, and you can upvote other people's questions. So the more popular ones go to the top. Some people have already emailed me a few questions in. I apologise, I may have missed a few. So pop those questions back in the Q&A box just so we don't miss them and we can ask them. For people that want social, please, if there's anything, takeaways or learnings or feedback you have, please let us know. We want to share as much positive content as we can with people. So we're really excited to see what you guys sort of learn and take away from the session. Alongside me today, we have firstly joined by Steve Miller, who you probably know from Grow Physio, some of the webinars we've done, and he's co-hosting it with myself tonight. And our main speaker and guest, who we're very much looking forward to having a conversation with, is Dr. Dave Hancock. So huge thank you, Dave, for giving up your time this evening. It's hugely appreciated by us all. For those of you who might not be aware of Dave's work, and I'm sure a lot of people are, he's worked with some of the best players and athletes in the world. If we take a look at the football, worked in professional football for just under, I think it's 15 or 20 years, working at clubs such as Chelsea, Leeds, Wolves, Blackburn, the England national side in the World Cup and the Euros. And within those clubs, had responsibilities for the youth development, designing state-of-the-art facilities, treating and rehabbing all injuries, doing injury prevention strategies, managing medical teams. And I think you were the youngest head physio in the Premiership, if I'm right.
Years ago.
Yeah. Dave also set up Atherapy. It's a series of clinics that work closely with Virgin Active and have some of the top physios in the country working for them. There's also, which is quite exciting, an entertainment section of the company, which treats high-level celebrities and musicians, providing physio and medical support on tours around the world, which again, we can kind of delve into throughout this session. And also Dave's now dialing in from the US, which is where he's currently based and has had roles at New York Knicks as performance director and Washington Nationals, and runs a clinic in Manhattan alongside running company Apollo V2. And not to mention also performance consultant for Nike, published articles, qualified strength coach, and holds 2 master's degrees in sport and exercise medicine and manipulation. I'm sure I've missed about half of your CV and experience off that, Dave, so apologies if I have, but the list is very long. I think for us, if we start just sort of going a bit general, what are your thoughts on injuries and physiotherapy, and how has that changed throughout your career?
First of all, thank you very much, everyone. Thank you to Physique for having us, and Steve for joining and chewing the fat, as I used to say. I think physio, in my view, has changed quite dramatically. I think the manual side of therapy has changed quite dramatically over the last 10 years. I think there's a lot of cross-connection between osteopathy and chiropractic work. And I think I've taken a lot of experiences and knowledge from my peers in those different areas. So I think one thing that I would suggest highly to people on the call is, if they're trying to develop, is to open your expansions into their mindsets, to try and experience some working alongside chiros and osteopaths. And I also think that over the years, that I've learned that not everyone has the perfect answer. And what works for one doesn't necessarily work for another. And I think that's really important, that, what the textbooks tell you is not always actually what's going to happen. And I think learning from your experiences and learning from your toolbox to affect something and quickly make a decision on changing your treatment regime or your rehabilitation regime if things aren't progressing in the right way. But I still think that there's some underlying science. I still think that there's some underlying principles that I think are often missed. I think principles in rehabilitation, especially rehabilitation, are often missed. I think people try to jump too far forward, or they don't progress quick enough, or don't progress things in the right methodology. And, you know, for instance, you know, you don't get the correct range of movement, and all of a sudden you jump into strength or power work, and, you know, someone's still got an effusion on a joint, or someone hasn't got full range of movement, and you're trying to get them to the next level before actually going through the basis of getting physiological and accessory movements in a joint. So I think they're the things that I think have changed for me, and changed in my view over physiotherapy over a length of time.
Perfect. And I'd be interested to see, so you started out early on at Leeds Rhino working in rugby league, and then early on into football, and probably, well, it's definitely changed from when you started in the sort of early 90s to in the 2000s and so on. And so what sort of comparisons or I suppose learnings would you take from working within professional rugby or football, and as it's developed, and what kind of advice would you give people if they were working in those areas?
So it's a very different environment to working in a clinic or hospital, for sure, especially when you're full-time. You're under, depending on what level, you're under a lot more pressure. Okay, so you have less chance or opportunity to make mistakes. And I think there's a heavy bias in sport on rehabilitation. I think that, you know, the thing that I really learned over the years is how to be good at rehabbing and getting someone back, and not necessarily just thinking about that injury or someone post-op, to actually think about holistically what that athlete needs to do when they get back doing what they do on a daily basis. So there's a lot more that's gone into it over the years. Now we've got a lot more data, so we've got a lot more objectivity than what we used to have, say, in the early 90s when I first started, which can be very helpful. And you can see your progression lines using data. I don't think it's the be all and end all, but it's definitely a help to have that objectivity on what you're doing.
Yeah, perfect. Steve, so Steve, obviously into the private clinic and working professional sport as well. Does that sort of resonate true with you, or any sort of comments and stuff that you want to add to that?
Yeah, absolutely. I think there's a few bits. I mean, I know that Dave is a self-confessed practitioner, and he's obviously keen on his research things as well from that. For me, you obviously touched on the sort of toolbox of things and how things have changed over the last, say, 10 years. And I think more than ever, there seems to be a huge shift sort of regarding manual therapy and where that sits within our profession. I don't know what your thoughts are from your journey that you've gone on in terms of where that sits.
Yeah, I think the manual therapy is very important, but I think I also realize it's not everything, right? So when you look at, say, what I've learned from other professions, the rehab part is the part that's missing, especially in my opinion, in private practice. Okay. And one of the reasons back in the 90s that I wanted to have, you know, the clinics, but I wanted to have them in a gym. And what I learned from sport was that we actually spend less time on the bed and more time actually in the gym or out in the field. And that's very difficult when you've only got an hour or half an hour with a patient. But the bottom line is, what I've seen on return or rehab, the more effort that someone puts in and the more designed that program is, the better your outcome measures are. And I think where people fail in, you know, reoccurrence of injury or coming back or not quite getting them to where they are, is that the body's really resilient to me, right? It can take a lot. And I've had discussions with my peers in the past about how much time you should be spending with the patient treating and how much more you can do. And I'm used to treating athletes for 5 or 6 hours a day. And it's amazing how much the actual body is resilient and actually can take on board what you're giving it. And I find that, you know, not always more is better, but generally from a rehab point of view, it can tolerate quite a lot. And you'll see quicker results and better results and less occurrence of injury by following that rehab pipeline. So my advice here is the manual therapy is great, and being able to manipulate a joint or release a tissue and everything else, but there's a lot more going on. And I see people do like fascial release work and think, oh, that's it. And it's like, well, how do you know that what you've just done is actually going to be long lasting? Because if you show me 5 research papers that say, yes, it does, and we've seen good results here, I can show you 5 research papers that contradict that. So that toolbox effect for me has to be both manual and rehabilitation. It can't be one or the other. And I think there's a big mix between the two, and depending obviously on the client, depending on what their outcome measures are, depending on what your return to play, if it's an athlete, is, it depends on how much of that you do and when you do it. And that then becomes for me an art, because we all have a great education and we also can do all of the MACP and the masters and doctorates and everything else that we can do. And we're very much, knowledge is great and study in academia is great. But then you're dealing with actual human beings who are all very different. And especially in the sporting environment, like I said, what works for one doesn't necessarily always work for someone else. And it's having that art to be able to know when the right time to do something is, when the right time not to do something. We also have a thing, I think over the years, I used to be like, oh, well, let's throw the kitchen sink at them. More is better. And then over the years, there's times where I've done too much and I've actually aggravated or made things worse. And sometimes the hardest thing to say is actually don't do anything because physio is not going to cure everything. So sometimes by just letting human nature take its course actually can be very beneficial, because the human body for me is like a fascinating machine that is self-sufficient. It learns ways to move. It learns ways to repair. And sometimes I think as practitioners and therapists, we forget that. I think a lot of people think, well, only I can do this. And you definitely need this to do that. And I think over the years, I've been very much like, there's several different ways to skin the cat, including rest.
So exactly. I think that's a really useful point, actually, because you've got all these tools in your toolbox, haven't you? And I suppose I did a talk on a syndesmosis injury. And actually in the early stages, one of the worst things you can do is force that range of motion, isn't it? And really drive manual therapy. And I was sort of very guilty of that in early days. So I think some of it comes with patient mileage, doesn't it? The more you see, the more you're more confident with, this will get better at a certain time, really. But we have to appreciate and recognize and respect that healing process early doors. But yeah, it's great.
And so another thing we've talked about before, Dave, is your blind screen approach. Do you just want to tell the viewers and everything what that is and what that entails?
Yeah, so this sort of came about through almost sort of self-testing myself. I was very much like, we're taught to take a subjective, and then as you get better at subjectives, your brain starts to tell you that it's either this or this, okay? And then you can go through a differential diagnosis to get a diagnosis that, is correct from your objective and your subjective examinations. And the subjective is huge, and I'm sure that everyone understands that it's really important to identify what type of pain, what issues, how it happened, mechanics, very, very important. But what I also found when I used to go a lot with the athletes to see surgeons is that a lot of times they're putting scans up before they've even examined the patient, that, it's like, well, let's home in on this. And then also I'm very curious. So I'm very much like, well, how did this happen? Why did that happen? And I've always gone back over the last 10, 15 years of asking the why. So what I started doing was I started having people come in, and obviously I'm having a whole different athletes, especially the athletes were coming through. And then I've been advising athletes on programs and training programs and prevention strategies. So what I ended up doing was I was like, I wondered if I can just get someone to come through and literally they don't tell me anything about them. So what I would do is I'd put together a physical orthopedic assessment, head to toe. I'd look at things very holistically about movement. I'd introduce different ideas on movement patterns, whether that was Mark Comerford's work, whether that was Diane Lee's work, things that I've sort of experienced working with these people and seeing different ideas and philosophies of whether it's about the hip or the pelvis, And then I put together this sort of program of watching, observing, feeling, touching, moving. And it would take me about an hour. And then I would find these flaws. So a lot of it for me stems from around either nerve or around the hip and the pelvis and the lumbar spine. I think they're areas that are very intriguing about how the body actually moves. And what I also believe is that no matter what injury someone has, they're going to move, right? We are built to move. And I think how injury occurs is that people don't properly rehabilitate a previous injury, whether it's you fracturing your ankle when you're a 10, 12-year-old kid, whether you have an ankle injury or a knee injury or a lower back injury when you're in your 30s, and 10 years, 15 years later, you've learned to adapt and move and sit. And I think those adaptations sometimes can lead to flaws. And I think if you can identify those flaws and you can try and correct those flaws from doing, in my sense, this blind screen, you can start then putting this jigsaw puzzle together and look at movement in a more efficient way and allow the body and the pelvis and the lumbar spine to move efficiently. So this blind screen idea has sort of led me to keep on doing this, keep on testing myself. And what I found was that by identifying specific flaws for each human being that I've been asked to look at, whether they are a CEO, someone sat at a desk all day long, or whether it's, Kevin Durant, it's the same principle. And you'll literally try, by addressing these flaws, you can start putting together a package. And it might not necessarily be around the injury, but my view is that I think those things are the why. I think those things have contributed to why that Achilles has ruptured, why someone has torn a hamstring, why someone has persistent lower back pain over multiple years of treatment. And sometimes by doing it blind, you're not then leading down like the doctor or the subjective to say, you've got this and this, I think it's that. You're being much more, you've got to identify and be a detective about what it is that's going on. And when you are like that and you haven't got all the information, things then don't get missed. And one of the things that I learned the hard way is when you're in sport and you're at the top level, you're very reluctant to really ask other people to come in because you feel quite threatened about someone else coming in and making you look stupid in front of the athlete or the club, because you're obviously paid to do that job. And you think what you're doing is absolutely correct. And as I sort of got older, I started realizing that, you know what, many people can do these treatments. But the real advantage of being really good, or being elite, if you like, is to actually listen out and let other people come in and give you their ideas about certain injuries and philosophies. And that then led me to really understand that, there's many different ways that you can treat someone. And there's not a right or wrong, as long as you're safe and you get your results. But the art for me is that identification of the why. I think sometimes we don't do that. I mean, I know we're not, in clinic settings, you don't really have the time. But my view is, like I say to my physios, make the time, because actually identifying the flaws or the issues, and it might not necessarily be anything to do with that joint. It might be to do with something else in the body. But the mechanical chain of the body is really what fascinates me. And that's how this whole blind screen sort of came to fruition.
Brilliant. And Steve, do you sort of have any comments or further sort of notes on that at all?
Yeah, I think people will be fascinated to know how you then go about weighting how much of the, say, lumbar, pelvic, hip complex issues that you find maybe relate to an Achilles, and how you, if you wouldn't mind maybe talking a little bit about sort of how much time, where you decide to focus your attention. I know every case is different, so it is a little bit tricky, but like maybe some of your thought process on where you go with that.
Sure. So I think rotation of a joint is a really problematic problem in the torque chain, okay? And I think rotation, which most sports involve rotation, is where the most force occurs on control, especially around the pelvis, the SIJ, and the hip, especially around the hip. And I think what the body needs to be able to do is to fix an area, a joint, and allow another joint to move. And obviously, as that joint moves, whether it's, you know, if you talk Comerford's work, like low threshold, high threshold, fast or slow, there's different mechanical mechanisms, tissue mechanisms, whether it's an eccentric, isometric, a factor, concentric factor of a muscle or a tendon that's affecting the joint. You need to be able to stabilize one area to allow another area to move. And I think that a lot of the adaptations that come over time from either inappropriate or not enough time rehabilitating a previous problem, or just human adaptation, like sitting, position that you sit, desk work, you know, the way that you run, the mechanics, the body will find a way to move. And over time, you end up with these tissue adaptations and joint adaptations that can lead to these, what I call dysfunctions. So the pelvis, specifically around the pelvis for me, I think internal and external obliques are fascinating muscles. I think sometimes the ability to work with an internal and external oblique and your glutes and stability around the hip, and especially rotation and abduction of the hip on a fixed pelvis is very important. And they're areas that I really focus on. Is that you see a lot of hip translations, say, for instance, with pincers or labral issues. And then over time, you know, you see all these diagnoses like labral tears. And, you know, a lot of people have labral tears and therefore never have any issues. But because someone's in pain, going back to that question, why? Why has this occurred? So rotation and stability, stabilizing one area, especially around the pelvis, and being able to, for instance, abduct your hip on a fixed pelvis in a bridge, rotate your hip on a bridge is another test that I do. Weight bearing tests, deceleration tests like hopping, holding, stepping, balance. Just literally ask someone to stand on one leg and drive the other knee up and down and see what you see through the lumbar spine and the pelvis. Are you stable? Do you get shift? Do you get rotation? And then the forces that the sports allow, and as I said, rotation for me is a big element. And when I rehab people, when we get to the right stages, I put a big emphasis on that rotational stability mechanics, because, you know, most of the time we're not just moving in one plane, we're moving in multiple planes. And a muscle or a tendon around a joint and a ligament to an extent will adapt. So, you know, a hamstring muscle, for instance, will work differently at one end to the other at the same time to compensate for something or to stabilize something. And the other thing that I find that's missed is people like, for instance, if you talk about Achilles, everyone's like on about eccentrics, eccentrics, eccentrics. But isometric and being able to position joints in different positions, including angles, is actually quite a good way in the early stages to actually rehabilitate and get activation through to a muscle or a tendon. So again, that toolbox, but thinking not just that this thing just moves in one plane, because they all move even very small amounts. If you talk about, like you were mentioning about syndesmosis, you know, the talus, there's a small amount of rotation that occurs. There's a small amount of adduction, abduction that occurs between the subtalar joint. So it's not just a question of we've got to get dorsiflexion, plantar flexion back. You have to think about the different angles that your foot would be in when you're playing soccer or jumping or landing. And that they're the points that to sort of look at, not only from a mobilization point of view, but also from a stability and a strength point of view. Yeah, probably going around the houses too much.
No, not at all. And I think people will be desperate to know, as always, about treatments and where you're, in terms of the rehab side of things, really. But are you talking about, so say you're working a lot on the isometric hold work, which I think there's huge amounts of evidence that, or sort of what I see clinically, that it's really beneficial, particularly some of those longer holds or even the dynamic isometric work. But would you sort of have a trail of thought that maybe you'd bring in some of the anti-rotational elements into some of those exercises, or do you keep them separate?
No, it depends on where the stage is. As I said, you know, the muscles and tendons are obviously working in syncs, right? So an agonist and antagonist are constantly changing very fast. And whether you move between isometrics in different planes, different angles, different, you know, lateral to medial, so tib post, perineal, you know, both of them are going to play a role in stability of the ankle joint, if that's, you know, the route we want to talk about. And the same with Achilles, right? So a lot of people do now a lot of isometric holds on Achilles, tendinopathies, you know, even ruptures, and changing the angles and thinking of length tension relationships of the Achilles. But the Achilles twists. So if you're only doing an isometric in one plane, right, what happens when the foot does that or does this? So the isometric holds for me don't need to be in just one plane. You need to think about the anatomy and the stress of the medial and lateral side of the Achilles tendon in that regard. So the rotation of isometric holds is really important in the rehabilitation, especially in the early stages. And then as they develop on and you start moving into movement and decelerations and then thinking about speed, because again, people, I think in the rehabilitation realm forget that the speed is actually what is going to push this load up. So I've seen so many people try things, you know, start getting to do speed quicker, and they end up wondering why they end up with a synovitis or a re-tear of a tissue, because they haven't thought about the process of doing things slow, controlling stability, and then progressing that speed. So I overlap things a lot. I don't just have like one box, we're going to just do an eccentric work today. Another box, we're going to do, you know, an isometric session today. There's a crossover. And I think also understanding the physiology and understanding the recovery. So when you're doing those sets, and, you know, if I'll give you an example. So an NBA player, if you're doing, say, sets of 5 isometric holds on an Achilles tendon, right? And you do 2 or 3 minute recovery on maximum effort on isometric holds on Achilles tendon. And you say, right, we're going to do a set of 5 of those. Okay. And we'll do them 3 times a week or 4 times a week. In the early stages, that's fine. But a basketball player will go out and jump 200 times to shoot hoops. So that recoil mechanism of an Achilles tendon is basically being pounded full body weight from a height 200 times. So I look at that and think, well, what are my sets of 5 going to do to that when the guy is going to actually go out eventually and do 200 of them? And these are things where you start thinking about actually, you know, 3 lots of 10 or 3 lots of 15. I mean, my personal opinion over time, I've just blown that up. You got to think about what that actual person's going to do. If a guy's going to go run 6 or 8 or 10 or a marathon, how much poundage is that ankle or that knee or that hip going to take? So therefore, you need to get that resilience in that tissue or that joint to be able to do what it does. So therefore, your 3 lots of 10 or 4 lots of 10 or 4 lots of 15 or 4 lots of 20, waste of time. It's, in the early stages, great, but not to get to the level of resilience of what the body actually is going to do. Does that make sense?
Absolutely, yeah. I think it always has to be very specific to whatever that individual's doing, doesn't it? And I think that's your take entirely, isn't it? Or seems to be.
Yeah. I think we've been taught stuff that, you know, and we've obviously been taught to be safe. And I understand all that. And I understand, you know, muscle recovery and all the things that were going on with, from, you know, muscle physiology and actin and myosin and rest recovery and length tension relationships. And I understand all that. But the body's really resilient, right? It does some amazing things, and people do amazing things. So therefore, you know, think a little bit wider, think a little bit about that person, what they want to do. They've got injured, but what is it that they want to do and where do they want to go? And obviously everyone's at different levels, but people, you know, who want to run, people who want to, you know, go up and down the stairs, and there's still a resilience of what that tendon or joint or complex chain need to do to withstand and not get injured or have pain or a problem in the future. And that's, I think, probably that, and the sort of blind screen and the philosophy ideas that I've picked up is probably where I've changed tremendously over the last, let's say, 15 years. And I think I've been doing this like 26, 27 years now. So, you know, I've seen a lot of stuff and a lot of change, and made a lot of mistakes.
Just on the prehab side of things, Dave, I've got a question that's actually come in, and I think they're flying in at the minute, so it's great. I think we just want to pick up on a couple. So how about prehab? So preventing and preparing instead of treating, preparing the body to be more resilient in case of an actual injury. In case of actual injury. So, what are your thoughts on the prehab side of things?
Pelvis, hip, lumbar, spine. Concentrate on those areas. And I'm not just talking about just doing glute bands, because everyone does glute bands, right? Is identify on that individual, what are the problems? Is it a stability problem? Is it a length tension problem? Is the psoas long? Is it functioning to stabilize the hip in the capsule? What's moving, what's not moving? What's shifting, what's not shifting? Why? Identify that. Can they balance? Can they control? Identify that. And that's, you know, at the basis of putting prehab into place. And then the question then of the prehab is like, how often, when? So my view is, what I find is if they can activate and neurally activate something that's flawed, let's say that, you know, it's a flaw of a psoas, or it's a flaw of a glute med activation, or it's a flaw of multifidus, or flaw of their external oblique when they stand on an opposite side and rotate. Work on those flaws, work on those neural inputs prior to doing their sport. And therefore, what I find is by doing that, there's less chance, or they come back to you and say, actually, I had less pain doing that. Actually, I felt better. Actually, my times have improved. Actually, I've been able to lift more. I've actually felt more flexible. That's the area that I would, you know, it's a big subject, which we could talk for hours on, but as a guidance, that's the areas that I would concentrate on for prehab. Balance, neural, pelvic, hip, lumbar, spine.
Dave, just on that, really, I think I know your trail of thought on this anyway, but it might be good to sort of explain to people as well. If there'll be people who work within sporting clubs at various different levels who are watching this, really. So from a pre-season screening process, what would your recommendations be for that?
It's the same thing, you know, there's a whole, in sport, depending on what level you're at, but there's a whole thing now where sports science has come in and they're basically doing, you know, Kangatech or Nord board, and they're doing isometrics or eccentric controls, and they're gathering data, and it's good, it's useful, but it's not the be all or end all, right? So when you're testing in eccentric, you're doing a Nord board or Nordic, right? And you're testing the actual pressure that your heel goes in against a sensor, because that's basically how they measure the measurement of power on an eccentric control, or an RSI, for instance, on a force deck, like how long you take to spend in the air, and there's relevance towards speed. But there's a lot more that's going on with how that muscle, tendon, joint, lever works. And I sometimes think that, again, you know, the technology is great. It's not the be or end all. You know, the bottom line is that you're trained to visualize things. You're trained to look at movement. You're trained to feel and touch and understand, you know, anatomy, physiology. And if you can see that and literally put your eyes to it, and go back to sort of the blind idea where someone's walking in, they're stripped off, and you go, right, let me just see you touch your toes. Let me see you stand on one leg. Let me see you move that hip really fast. Let me see you jump. Let me see you land. Let me see you run. Let me see you move laterally. Let me see you walk backwards. Simple stuff can actually identify a lot more in the chain to what you're going to get from just doing a Nord board or a force deck test. And, you know, I think we've sort of taken, you know, going back to the basic stuff is what the area that on a screen is where I would go. And that idea of testing yourself. So don't know anything about them. Don't ask them any injuries that they've had. And in those screens, and, you know, I've done thousands of them now. What I find is, remember, I don't know anything about their past medical history. And what I find is that people who've had surgery or people who've had problems, you can identify it, because you're not basically homing in at the previous thing that they've told you. And if you look at things logically and you assess and you try and put them into sort of, what I say is I put them into sort of clusters. So that could be linked to this. So let's say, for instance, put someone in a bridge, get them to abduct their hip, okay? Their pelvis drops. They haven't got control in the outer range. You then go and test their adductors. You find that they're weak their adductors are weak outside. You then go and test the internal or external oblique on the pelvis. So now what you're finding is that there's weaknesses in different areas of the chain, which is actually resembling the test that you've actually done. And then they're the identifiers. And what I put them into is like, what's the major and what's the minor, and try and work on those two. And if you haven't got time, work more at the major, because the major, it might be psoas control. So that's much more prevalent to a hip problem than, say, a glute med or an external oblique. Because if they've got translation of the hip and it's keep on doing this, no matter what you do above it or below it, you're not necessarily going to get that control. So that would be a major, and the minor might be, for instance, an external oblique, a multifidi on the opposite side, or whatever you're seeing. So they're the things that I think are missed. They're the things that I would say from a screening category that I would be really homing in. And then all the stuff, the objective information, don't get me wrong, it's useful and I use it, but that's just almost like an add-on. I'd always start with like the basics, the feel, the touch, the look, strip them off, see how everything moves from the shoulders to the neck, to the rotation through the thoracic spine, everything standing, just simple stuff. And then you can be more dynamic with it, specific to the sport. So like, you know, I had a tennis player where I was analysing the way that they serve, and literally I had them on a court virtually naked and basically doing the serve. But the thing was, that's the only way that I could identify everything that was going on. But at the end of the day, the guy didn't, you know, this is his life. He wasn't bothered. The bottom line was, can I identify what's actually going on within his mechanical chain? And they'd done, in this particular instance, they'd done a ton of Viacom, which is the three-dimensional video analysis, the force. This is a top tennis player. They'd done everything. And it didn't identify what I was actually seeing. And I was quite surprised by that, because I was like, surely all this tech should pick this up, but it didn't. So I think, you know, your experiences, your what you see, you know, is really valuable. I just think sometimes we're blind to it, or we're twisted off, or we go down one tunnel and we forget about this. And that happens a lot in sport. It happened a lot to me. And really what happened, the telltale for me was that I had an athlete that came from another club years ago, and he played for Real Madrid, and he came to us and was having a horrendous time with injuries. And I started looking at him and thinking, well, yeah, it could be that, could be this. And I was like, oh, I'm not sure, and I don't really know. And then I was like, you know what, I'm going to ask someone. And it was the first time really that I did ask someone outside. And it was probably the best lesson and the best thing I ever did. Number one, for the athlete, and number more so for me. And this physio coming in and doing what he did led me to another view that, you know, actually it's good to collaborate and it's good to share information. And you've got to realize that no matter how much experience and qualifications, you know, you've got to leave your ego at the doorstep. You're not going to be able to treat everyone. And even just from a psychosocial point of view, your personality might get on with someone very well, especially in the sporting environment, but not so well with someone else. And that plays a massive impact on the return to play, and the criteria is the psyche. And that's a whole different topic of conversation. Does that answer your questions?
Just about, yeah. Fairly thorough.
I can be more specific. If someone wants to give me some, you know, specific problem or issue that they've got, then obviously I can home in.
Cool.
Is there anything else in the group, Charlie?
Questions? Yeah, so I was about to say, if you had anything further, Steve, to add, if not, I'll jump into the questions, because it's going a bit nuts. It's good to go into the questions, Steve.
Yeah, if you fire some of them off, and then I'll have a little think.
Yeah, so yeah, but says 20 questions. So it's brilliant for you guys to engage in this. So we'll start at the top. So it's going to be a bit of a far from the hip stuff. But could you recommend any books or manuals on sports injury diagnosis and treatment?
So, I mean, there's a ton. If you want something very generalized, Peter Bruckner's books are pretty good, and he's an Aussie doctor that worked at Liverpool, and they're quite thorough. In my MSc, we had Bruckner Kahn, which was more about injury and sports injury. So Bruckner and Kahn are a good book. And then you can be very specific. So, you know, if you want to look at knees, Robert Engel does a lot of good work on sports rehabilitation of the knee. I love LJ and Diane Lee's work on pelvis. I think those two girls are superstars. I've been very fortunate enough to work with them. I think they're brilliant. I think Mark Comerford's work is really good on control and looking at low and high threshold work. I think that's quite interesting. So that would be my sort of take homes. I love Nags and Snags, Brian Mulligan's work. I mean, you could go on and on.
That's good.
Butler. I think Dave Butler's a genius.
A good dresser as well, isn't he?
He's a dresser for sure. And if you've ever had the privilege of, if you ever get an opportunity to go on one of his courses where he teaches, do it, because probably one of the best, most entertaining, thought-provoking courses I've ever done. I don't think he teaches much anymore, but in the 90s, I was very privileged to experience his wit and his Hawaiian shirts.
Brilliant. The next one's come in from Alex, and he says, what advice or pathways would you suggest for a current university physio student who has the ultimate aim of breaking into sport and football further down the line?
Go and get as much experience as you can. Don't think that you need to get paid. Ring up your local teams, go and volunteer, go and spend time with a physio in a local clinic. Quite sad for me really last year, but my mentor was Neil Black, who was head of physio and then became basically head of performance at UK Athletics. And before I even went to medical school, I went to a local clinic in Epsom where I lived in Surrey, and there was a clinic there called City Sport. And I got introduced to this guy called Neil Black, and I used to just sit in a room and watch him. And then I'd throw a million questions at this guy. Why are you doing that? What are you doing that for? What's this for? Like a complete pain in his ass. And then as I went to college, I used to go back in the summer, I used to spend time with him. And then his career sort of started to pick up, and he was an international runner himself. And then over the years, when I started working in sport, we became good friends. And, you know, I always remembered the way that he used to do things and how the athletes used to love him. And his career went up and we became really, really good friends. And he was a massive help to me in what I did and where I went. Unfortunately, he died last year, even to the extent that he was actually going to come work for us last year after leaving UK Athletics. So what I would suggest is something like that, is just pester people. I mean, you know, there's some good people out there. I mean, a lot of people are busy and you'll get a lot of knockbacks, but it's like anything. If you talk to actors, you know, you talk to Daniel Craig and he tells me that, you know, how many times he got knocked back before he actually got his first break. It's going to be exactly the same in the physio world. So that's how I would recommend, you know, write to these teams, write to the clubs. Don't just be thinking that I'm going to go to Chelsea and I'm going to get an internship. It's probably not going to happen. But if you get an internship at, say, Charlton or QPR or even the lower level teams or the rugby teams, people will go out their way and do more of that. And that's really where you get a real feel about what it's actually like to work within sport, or go and work within a clinic and do exactly what I did with Neil Black when he was at City Sport back in the 80s.
Brilliant. I think there's some great advice in there. One thing I think would be great for you to sort of touch upon, and I don't know if people have seen the All or Nothings and seen Mourinho and how he interacts with the medical team, and you can kind of get an insight into the working relationships between coaches and the medical team. But Charlotte's asked a question along those lines of, in regards to sort of pre and post rehab when working across a clinic and sporting athletes, could you advise how you would implement this into treatment and get the coaches on board and into a plan? They're basically very much an amateur sport and they're fighting against the coaches and parents.
Yeah, very difficult at any level. It's more about the relationship between the therapist and the coach. It's more about education, because a lot of the coaches aren't educated and they're going with their gut or they're going with what you're doing. It's more about, in fact, even using objectivity of data in that scenario to actually prove that actually this could be better. And you've just got to keep chiseling and chiseling and chiseling and chiseling away. And you shouldn't take it personal. I'll tell you a good story, which again, just experiences. So I was at Leeds United and we were playing Liverpool away. And Peter Reid came in as the manager, and there was a whole financial thing going on with the football team at the time. And I was told that I had to lose some of my staff and I needed to make budget cuts. It was horrendous. But we needed to basically stay in the Premier League. And Peter Reid had just come in, and previously he'd sacked a ton of physios at different clubs he'd been at. So I sort of was on high alert. And we had a player called Lucas Radibi, who was just a warlord. And he had the most horrendous ankle injury, I think 2 weeks previous. So we worked around the clock and we had a couple of defensive problems. And I said to the coach, you know, he's a vet, let's just wait to the end of the week. I take him out on Saturday, we do a fitness test. If he's good to go, play. If not, we just carry on. Coach was like, yeah, great, happy with that. Player, yeah, great, happy with that. Took him out, did a fitness test, doctor with me, Peter Reid with us. We're on the side of a grass verge at the hotel. This is on a Saturday morning before we played Liverpool. And Michael Owen was playing up front and he was on fire. Lucas was about 33, 34, and literally I took him out. He couldn't move. He couldn't rotate. He was hobbling. He was in pain. And I kept warming it up. I did all the mobs, did all the manual therapy prior to it, flushed it, game readied it, did everything you can imagine to get this guy fit. Worked around the clock with him all week. And after about 25 minutes of just trying to warm this ankle up, I looked at Peter Reid and went, there's no way that he can play. Anfield, Michael Owen, no chance. Peter Reid took Lucas Radibi over to the side and spoke to him, and then he basically walked past me and went, he's playing. And at that time, I was probably 31, 32. I was fuming. I was absolutely fuming. I was like, how dare he? I've gone through everything, you know, ticked all the boxes, tried everything we possibly can. You know, he just needs longer. And I was really annoyed. I was just really upset. I was just sat at the front of the bus. I was fuming. Anyway, the decision was made above my head, basically strapped the ankle, went out. Lucas Radibi was world class. Absolutely world class. After the game, the ankle was like an elephant's hoof. But I learned a lesson that day that you can only do so much and you can only influence so much. And at the end of the day, he's the coach, not you. And if he makes a decision which you don't agree with, you've done everything you can. You know, I've literally given him the information to make the decision. The player has to agree to it. There's not much more that I can do. So that was a good lesson to learn. But my advice is just keep chiseling away. Keep believing in what you believe. And, you know, use objectivity if the conversations aren't working out. You know, try different ideas, different philosophies. Get the player more on side. Because the players are smart. You know, if they know if they're going to do something that's going to help them, they're going to do it at any level.
Yeah, brilliant. Do you have any further comments on that one, Steve, at all, or that's it?
I love a story, Dave. I always love a story, to be fair.
So do I. I've got lots of them. Some of them I can't repeat on this call, unfortunately.
Yeah, exactly. I just wondered whether, because there's different trails, isn't there, of management, with some physios will take players all the way through that rehab journey and reintegrate them back into playing again. Some people will have a rehab therapist that sits between them and S&C. Have you got any tips for anyone from your experience of ways to make that whole journey a bit more sort of fluent, if you like? Because everyone wants their pound of flesh, don't they?
They do. Yeah. I mean, I've obviously changed and had to adapt, but I was very much like, if you've got good enough staff, you should let that staff take them right the way through. The back end of the rehab, like the specific skills stuff, which, you know, not everyone can basically take a Premiership footballer out and run them through drills on the grass that's relevant to what they're going to do in training. But my view was always that that person should be a lead and that they should be able to see that all the way through. I've seen, and I've had to adapt to that, because then I've now on the other side of the fence, I consult, and therefore I have to just do my thing, step back, and then let other people do theirs. I think the biggest thing there is the collaboration and sticking to the plan. Where I've seen that fail is that whether it's the rehab guy or the fitness guy or someone, like, it just pushes a bit more, and then something happens, and then it's all a bit of a blame culture. You shouldn't have done this, you shouldn't have done that. And I think the communication between those team that are working with that individual is absolutely key. Trust, absolutely key. And if you don't trust that person, then there's always going to be a doubt in that flow. So my view is it's a question of having a really good team, having a group of people that you can challenge, having a group of people that you can disagree with and they don't take it personally, but sticking to the plan of the return and ticking all the boxes or the outcome measures or however you want to do that progression back to play. But me personally, I've always liked to put someone with someone to oversee it right away from point A to point B. And if you've got good enough staff, they should be able to do that.
And so we've got another question here. So, and you probably could have a story in there, I'm sure, as well. But what would your main tip to a therapist starting out in professional sport? And how did you feel first going into that environment?
Petrified. I would be energetic, enthusiastic. Don't be arrogant. I would go above and beyond anything. You know, whether it's emptying the bins, cleaning the beds, do it all. Don't go in there with an ego. Don't think you know everything. And even like, I don't know everything. And I absolutely admit I don't know everything. And have that mentality to what you do on a day-to-day basis. And have fun, laugh, don't take things seriously, don't take things personally. And just interact with people and, you know, be a sponge. Learn from everything that you see, not only within the physio world, but every other world. I mean, I've learned so much sitting in dressing rooms and watching people like Jose or Phil Jackson or, you know, Graham Taylor, who was my first manager, God rest his soul. I learned so much about different things, you know, not only to help in what I do from a physical therapy point of view, but also in business, preparations, and then mistakes, you know, things that you learn that you just like, okay, that can't happen. I've got to understand that what the consequences of that are, or, you know, where I've screwed up and where I basically tried too hard. So they would be the guidances that I'd give someone coming into sport or pro sport or amateur sport. Have fun, you know, don't take yourself too seriously, learn, be a sponge.
Did you find that quite difficult to say not take it too seriously, because especially working in high performance cultures, in if you're seen maybe having a laugh or whatever, enjoying it, but at the wrong time, does that ever sort of bring up conflicts or anything like that?
So when I say have fun, I'm not saying like you got to be Coco the clown, right? So
yeah.
Obviously, you know, you're in a job, you got to be professional, but you got to be you. Mm. Why try and be someone else? And my view is, you know, and this has happened to me. If people don't like you and people don't like what you do, then the view is, well, why should you change for someone else? You know, I'm really confident in what I've done, what I am, who I am. I know how bad I am at certain things, but why should I change? I love what I do. I'm passionate about what I do. My view is, as long as you're professional, you shouldn't change your personality. And I actually think some of the best physios that I've ever worked with, some of the best physios that I respect and seen, 9 times out of 10, they've got really good personalities. And I think the personality with the client actually is a huge benefit to actually getting them better. You know, going along that psycho, I really do. Because sometimes I look at things and think, I didn't really do much there, but they seem to be better. And I don't really understand why. And then sometimes I think it's just probably because they've got confidence in me, or I've rested their mind. You know, I've eased their stress or their tension about what they're thinking about, or, you know, and that's a huge benefit. So my advice is be yourself. Don't try and be someone that you're not.
Yeah, definitely. And so another question's come in, which could probably spark conversation that could go on for hours, but have you worked with many sports therapists? And if yes, have you seen a difference in the practice of physios and sports therapy?
Yeah, so I used to lecture a long time ago at Salford on the sports rehab course when I was at Blackburn in the 90s. So I think Kevin Foreman was the guy that started that. And I actually employed a couple of sports therapists. In fact, Harvey Sharman, who's now at the Washington National, was a sports therapist and then went on to do, after he did his Bazarat degree, he went on to do physio. There's always a big, you know, well, I'm a physio and you're a sports therapist. But there are some really good sports therapists. And I think at the end of the day, it's just a question of
learning, being safe, and like I said, just venturing out and just learning from other people, whether it's a masseuse, whether it's someone who does, you know, P&F, whether it's a strength coach. Go out and learn from all those people, study, and just get more and more information. Because I've been in rooms with sports therapists who are actually very, very knowledgeable. And I think a lot of physios put them down because they haven't followed the route that you have. But for me, that doesn't mean anything. At the end of the day, you're good at what you do. You get people back. That's what matters. What matters is your patient, not what someone says or someone else has an opinion on.
Yeah, perfect. Yeah, if there's Steve, if you see any other questions that pop up in the Q&A box, just shout them out if you think they're worth asking at the minute. So there's about 26 in there still. We obviously will go through a few more because I'm conscious of time for you, Dave. But
I'm okay for time if everyone else is. I'm not.
Okay.
I've got to be at. I'm going to the US Olympic Center today. I'm in Colorado, so I've got an hour. So we're good.
Cool. So one is quite a quick one, so I'm just scrolling through because it's just shot up the screen. So it's they're just, I think they're here we go. So in the process of building and converting a private clinic, what are the key items for a rehab space? And room is limited.
Yeah, good question. So functional, use the walls. So you can store a lot of stuff on the walls to give you space. I think if I had a small room, like a bedroom, I would have a physio ball. I would have a BOSU. I would have some bands that I can attach. I'd have a pulley system, weight pulley system that I can interact. And I'll have some dumbbells. And I think you can do a hell of a lot with just those pieces of kit. So, you know, they're the key main things that I would use in rehab. I don't think you need to have loads of gym equipment. I think the pulley system is brilliant because you can do so much with it. Whether that's a Kaiser piece of kit or whether that's an actual pin on a weight. I think BOSU or the fitters or even the rotational discs, I use them a lot from Pilates, the discs that rotate. Sliders, I use a lot. You know, you can just improvise with all those pieces of equipment. I do a lot of work kneeling on a physio ball, a lot. So I really do a lot of perturbation through the lumbar spine, lots of multifidus activation, but get someone to actually kneel on the ball and balance. And then you can introduce all sorts of different movements or retraction work for shoulders. But I find that really beneficial. It's weight bearing through the lumbar and pelvic spine. And it's, you know, you try one and get on it. And then you can play around with inflating and deflating the ball a bit to make the thing difficult or easier for the patient.
Perfect. Steve, any that jump out at you?
Yeah, there was just a couple. So I think one question for me would be almost, Dave. So I've been lucky enough to sort of work and go on a Diane Lee course and things, but I know not everybody will have had that luxury really. But I know every situation is different and every athlete will present differently and you want to go down different clinical reasoning routes to test things. But is there sort of a protocol-esque or a route, like if we want to know more about your blind screening approach really, is there somewhere that people can go to learn about it so they can sort of almost practice that process?
Not really. I'm not huge. I'm a bit old school, if I'm really honest. I'm on LinkedIn, but I'm not huge. The company has stuff on social, but I'm not a big social person. My view would be that, you know, if this was of interest to everyone on the call, I'm happy to do some sort of practical physique to actually go through some of that and have a patient. That's easy. I'm quite happy to do that for everyone. But this is not something that I have the time really to sort of publish or teach. I just think it's just a good idea for you to think about how you could do things differently. And I just think that subjective is not, sometimes it blinds you from, you know, you go straight in for the kill. And sometimes, yeah, you might get the diagnosis, but why? Why has that occurred? You know, and sometimes then it's missed. And that would be the take home, because you guys on this call are all really good at assessment. You're all really good at watching people move. You all got your own little techniques of how you want to test it, whether it's a step down, whether it's a hop, whether it's a soleus control up on your toes, whether it's looking at, you know, Diane talks about the glenoid translation on basically bending forwards and bending, whatever it is that you have learned, put them all into sort of a big soup and be blind and go through all the tests. And then some of them are just purely just like normal muscle tests, looking at, you know, firing patterns between glute and hamstring on a hip extension. You know, these are things that you will do or you have done, but you probably haven't thought about putting them all together. So I'll be honest with you, I'm so busy. It would be lovely to just put all that together and go and teach it as a course, but I just don't have the time. But I'm happy to do something and answer questions if it's of interest to everyone. If Physique want to do this again, where I'll get a patient or an athlete and I'll go through points of what that screen would entail. No problem.
Yeah, brilliant. I think people would love that. So let's try to get a date and diary to do that. Appreciate obviously time and everything at the minute. So yeah, let's work to do that. That'd be awesome. Got a question here. So there are so many elite athletes that have odd movement patterns and are still elite athletes in their field. So how much do we prehab and / interfere?
Yeah, great question. So I think the key is, you know, if they don't get injured, then we don't really need to do a lot. Okay. So if it isn't broken, don't fix it. So you don't have to change things in that respect. What I tend to see is I tend to see people who've had one problem and another problem. And there's something of their why that's happening. And they're the people that I would concentrate more on. And I agree, you know, a golfer or a tennis player, you know, you're never really going to change the capsule or the strength or the difference in ratios between internal and external rotations of the shoulder or scapular control or whatever it would be. If they're not having issues, then my view would be, you know, there's certain things I think that you can work on to improve performance. And I do think there are key elements, especially around the pelvis, that I don't think there's necessarily going to cause an issue. I think the pelvis and the hip is a fascinating area for me with the lumbar spine. I find it intriguing, especially with thoracic rotation. But my view would be that, you know, if they're not having issues, then you don't necessarily need to go in and start changing everything.
Perfect. Right, a couple more. So one that's it crops up a few times in our webinar, and it's quite an interesting topic at the minute. But Sarah's asked about she's retrained to be a sports therapist, and she worked in years as a commercial in commercial sport. And she said it was tough working as a woman in football, and that was in the boardroom. So what is your view and advice for young girls and women trying to advance in professional sports like football and rugby?
Don't give up. I'll tell you a story, another one. Mm-hmm. So when I was at Leeds, we interviewed for an academy physio, head academy physio. And there was a guy that you will all know, I'm not going to mention his name, who basically was telling people that he'd got the job. And I knew him. So I was like, well, let's just go through the interview process. And, you know, I knew that he was, you know, the favourite, if you like. And I interviewed this girl called Donna Gormley, who ended up going to the FA. And she came from rugby league at a lesser level. And this girl just blew me away in interview, like just on another level. So we brought them back for second interview, and we had final interview between the guy that was shouting up and down and telling everyone, even on social media, that he was going to be this position within our club, which I think was completely wrong to do, and this girl. And I was like, I've got to work with this girl. She's just amazing. There's everything that she's, you know, she's ticking all the boxes. And then I spoke to a few people about her, and everything was coming back was positive. So I said to the academy director that, oh, I want to go with this girl. And the academy director came back to me, and again, a famous soccer person, and said, well, we don't want a girl in the academy. And I turned around, and basically I went to war for this girl. She didn't know all this. And I have to tell you, it's one of the best appointments I've ever made. So don't give up. I think you'll get a lot of kickbacks. You'll get a lot of the male chauvinist view, but I think if you are good, someone somewhere will recognize it and give you the opportunity. But it's not easy. It really isn't, especially in a male environment. What you're finding here in America now is that a lot more women are actually coming in, even coaches. So at the Super Bowl, there was a female coach. We interviewed a female coach for the New York Yankees. And these are really, really talented individuals. So for all the ladies on the call, please don't give up, because it's really important that you stick to this and you get involved with it. And you'll find that people will endorse you. And I remember Donna, she had certain players, like international players, who absolutely loved her. They actually didn't even want to work with me. They wanted to work with Donna. And my view was, great, no problem. And she was an incredible physio. So any of you know her, please give her my best. It was a long time ago, but don't give up, girls, for sure.
Brilliant. Yeah, I think that's great advice. And it's interesting, you just obviously touched upon the American, what they do in the US, but what are your biggest comparisons in terms of, I suppose, working in professional sport and private practice and everything in the UK, and then comparing that with how they do things over in the US?
I think the training in the UK is better than it is in the US. I don't think there's as much manual therapy in the US. It's coming, but they're not trained the same way. They're not trained in America to diagnose. You're not allowed as a physio trained here to diagnose. They're very much protocol driven, and they're also very much insurance driven. So the way that insurance works here is that you will get so much money for doing different therapies. So what you end up finding is that someone will come in and have a hot pack, and then have some ultrasound, and then have some manual therapy, and then have some exercises, because the clinic can bill for all five. Whereas if you just went in and did manual therapy, there's only so much you can bill. So it's flawed. It's massively flawed. And when I went clinically, I'm out of network. So I literally, like, there's the price, you pay me, I give you the invoice, you deal with the insurance company. I don't deal with them. And I think it's getting a little bit like that in the UK. The insurance companies, for those of you who are in private practice from running a company and a business for so many years in the UK, the insurance companies are now starting to squeeze us. And I don't agree with it. My view would be that you should have time. You charge for your time, but the more time you spend with someone, the better it's going to be for that person long term. For those of you who are interested in coming to work in the States, it's probably the best thing I've ever done, but it's very hard. You have to sit the board exam. So after like 20 odd years of being a physio from the UK, I actually had to go back to my books and learn my pediatrics and my burns and all the other things that we did when I was at college to actually sit and pass the certification board exams. You can't just come into the US and work. It's very difficult. So you can do it, but you have to go back to your studies to actually get into the United States. And then obviously you need a sponsor and a visa.
Perfect. One thing actually has just come in now. So on the blind screen assessment, are you prioritizing starting from the ground up or from the head down, or is it dictated to by subjective info prior to the objective testing?
No subjective. If you're getting subjective, you're not blind. Okay. So literally someone walks in, you get them stripped off and you look at them. So the way that I start with it is I look from posterior, anterior, from the side. I get them then to move. I get them to walk. I get them to stand on one leg. I get them to jump. I get them to hop. Various different other tests in weight bearing. I get to look at the control of what their body's doing in certain movements, whether that's a lunge, whether that's, like I said, that's where I'd start. And then that identifiable area will then lead you to something. And then once I've done all of that, and I've done some other little tests, so like I look a lot on soleus control. So I look a lot of, can they control the heel down in various different angles and positions? So soleus control, psoas activation, shifting, movement, rotation. Once I do all that, then I basically go to the bed and I tend to just start at the hips. So I'll basically do the normal orthopedic assessment where I'm looking at passive ranges of movement, looking at quadrants. I then check all the ligaments, knee, ankle, lumbar spine shifts, pivums, pavums. then look around shoulder, thoracic mobility, shoulder assessment. So all of the assessment that you would do, I do. Okay. So trying to identify patterns, trying to identify, you know, is there a positive quadrant? Do they show signs of a labral issue? Does that have neural tension? All of that. Straight leg raise, the normals, reflexes, dermatomes, do all of that. But I literally, that's how I tend to go from looking at what they do. And I spend about 20 minutes of looking at them standing, moving, hopping, jumping, lateral movements, stability. And then once I do the full head to toe screen, if you like, on the bed, then I'll do some specific tests like bridge control on the bed. I look at glute and hamstring firing. I look at all of the nerves tests, obturator, sciatic, superficial peroneal nerve. I'll do those. Upper intention test nerves. I'll do all those. And then I'll put that jigsaw puzzle together. And then once I've done it all, I literally will sit with the patient and say, listen, this is what I'm finding. I find this, 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 and this. Now, tell me what problems you've had and what your past medical history is. And what you'll find, and this is what I find, is that it'll be one or two. Sometimes it's so, I mean, I'll give you an example. And I'm not saying that this works all the time because it doesn't. But I did one in front of a Major League Baseball, and in the whole medical department, there was like 15 people there. And I said to them, just give me any athlete. And I didn't know who this guy was from Adam. This is a Major League veteran player. And I went through the whole of this blind screen, and everything that was standing out was on his left side. Everything. And then when I sat him down after, he looked at me and went, how do you know all that stuff? And I was like, what are you talking about? He said, all my injuries have been on my left side. And I didn't know him from Adam. So that I can't prove it to you. It's not something that I can research and say, yeah, this works for this, because I'm a practitioner. But I do think that there's something there. And I do think that we get led down this path that's not always 100% correct. So it's great to be able to diagnose, sure. And then when you get diagnosis, you can treat the diagnosis, sure. But many physios can do that. They have different ways of doing it. But the harder thing is to go, why? Why did that disc blow? Why did that hamstring tear? Why has he got Achilles issues? Why has he got plantar fasciitis, or she got plantar fasciitis? That's more of the art. That's more of what the real substance for me personally is, to try and work that out. And you're not always going to find the answer. But I found that doing this blind thing, you're not judging straight away and homing in. Because the minute, someone tells me that they show signs of a hemarthrosis in the knee, I'm going to go straight in and think, oh, they've, torn their ACL, or they've had a dislocation of the patella, because that's what we're taught. Right? So the minute someone says to me that the knee swells within a couple of hours and it was warm, bang, that's exactly what I'm thinking. Someone tells me they got an effusion on the knee 24, 48 hours after, I'm thinking meniscus. But many people can do that. It's like, what?
Yeah. Dave, on that, really, do you ever use any sort of tests in the clinic? Do you mainly look at the control when they're performing these activities, or do you ever do sort of maximal reps, or how many repetitions of these exercises would you assess? Or have you got such a keen eye that you can pick it up in a couple, but other people, I think it's quite hard.
It's a great question. So I look at things slow, I look at things fast, I look at things deceleration, and I look at things isometrically. So I'll do all of it. So if I'm asking someone to do, let's say, a single knee bend, I'll get them to do that, and I'll basically be looking at, I'll strip them off. I won't just have them in shorts. I'd have their top off. I'll be looking from behind, from the front, from the side. I'll get them to do it slow. I'll get them to hold it at 20 degrees, 30 degrees, and then come back up. I'll then get them to do it fast. I'll then get them to say, do that and then jump, or step down slow, hold, step down fast. Where are the variables? Because as we all know, just even looking at eccentric control slow and eccentric control fast, there's a huge difference in the torque of what the muscle has to do to control. That's a great question. So I do all of it. And I think, from an art perspective, your eye gets quicker at seeing things. And then once you see it, you can then, then go more down that area to learn more about that and then come back. Does that make sense?
Absolutely. I think that's something that for me, I almost had to have in the early days, certainly someone with me pointing out the abnormalities and the slights, because they're really subtle for me, some of these little differences. So I think it's a really useful point, really looking at it at different speeds, because it can look great, can't it, in a slow, controlled fashion. But as soon as you go to an impact activity or that sort of higher level absorption work, it can really expose control issues. So no, thanks for answering that. It's good.
The athletes, in my opinion, seem to be better at things fast than they do at things slow, just in the nature of what they do. So therefore, if you get them to do things just purely fast, then it looks fine. But you actually get them to control, and also control and hold. So now, if you're doing a movement, can you stop? Can you move? Stop. Can you move? Can you move? Whatever it would be, whatever angle you want to do that. They're the things where people lack that control. And depending on the level of your client, at the elite level, the top guys need to have it all. They need to be able to, stop on a sixpence. They need to be able to stop, revert, change direction, whatever they need to do. And they need to do it 1, 2, 200, because that's what they're going to be doing in the game, not 10, not 20. And in real sport, if you think about it, they're not having a 2-minute break, right? So if you say, right, we're doing isometric and we're going to give you 3 minutes recovery, right? I understand the reasons why, but in real life, in sport, that doesn't happen. They're going to go, and they're going to go and go and go and go and go. So as you progress your rehab in the late stages, you've got to think about what is actually they're going to do. And therefore that rehab, that number, that time, whatever you use, you need to implement it, because the tendon or the tissue or the joint needs to be able to tolerate it.
Yeah, I think they're really useful points, aren't they?
I think sometimes in the latter stages that's missed. They think, they can run and they can strike a ball, or they can, hit a shot. And we've done it, 10 times. They're good. No chance.
I think that's when you sometimes find, don't you? Not many people have got an isokinetic machine or a biodex that's sitting next door, have they, to test all these things. But there's still so many really useful things you've dropped in there about sort of deceleration techniques and repeated movements and things that people can use. Like the question earlier on was, what do you do in an environment where you don't have much equipment? Well, there's still a whole load of things that we can use as objective markers, isn't there? So
I've used time a lot more over the last 10 years than I have reps. Okay. So I'll go do that for a minute. And then next time round, now do it for a minute and a half. The next time round, now do it for 2. So constantly pushing the boundaries on fatigue, and then, interrupting that with speed at the right time, stability, the right time. But I use time a lot. I've moved less away from here's a clinic band and go and do 3 lots of 15. I just think that's bullshit.
Brilliant. I think, we'll look to close there, I think. Is there any sort of final comments or anything, Steve or Dave, you kind of want to address, or just kind of make a point at the end at all?
I don't know, from me, a big thank you to Dave, really, for obviously joining us. And I think a lovely little secret compliment for me, Dave. I was actually with you as a young 3rd-year physio student at Leeds United when I came in for those 2 weeks, but I didn't realise I'd changed your practice quite so much, given that feedback for that player, which you maybe not realised until today. Yeah. So, big thank you for me for that, and then obviously for tonight as well. It's great to see you.
Yeah.
Thank you very much, everyone. And as I said, if you get some good feedback from everyone on this, I'm happy to do another one a bit more practical if that's what people will take away and be helpful for them. And if you want to contact me, you can do that from a couple of ways. You can get hold of me through the website, which is atherapy.org, atherapy.org, or my other company is apollov2.com. If you go to the info pages there, those emails will find me through the appropriate channels of our staff. And I'm also on LinkedIn. Again, you can just reach out to me on LinkedIn, and if you mention that you're on this course, then I'll definitely come back to you.
Yeah, brilliant. I think what we'll do when we send out recording and stuff of this to everyone that's attended, we'll put where they can find you, Dave, and I'm sure people have got other questions or advice and stuff, they can get in touch. But I think that was a fantastic conversation. I think there's so much. I mean, the chat box is just going nuts now saying thank you. So I think that's been very well received. So great to hear people's feedback on that. And again, thank you, Dave, for giving up your time and going through that. And thank you, Steve, as well, for co-hosting this evening. So yeah, big thank you to everybody. And yeah, I think we'll leave it there. So yeah.
Can I just say one thing before we go?
Yeah, go for it. Go for it.
What I see physio or therapy is as a hobby, right? It's the most amazing thing that you can do for your clients and your patients, and just explore it. And what I've come across people who've sort of got dumbfounded with physio and given up on it. And I just think it's an art. And the more you explore, the more passionate you are about it. Even after doing it for 27 years, I'm still exactly the same. And I think what we do and how we affect people is huge. So don't give up, keep chiseling away, enjoy what you do, because the profession that we're in, for me, is absolutely fascinating.
Brilliant. That's a lovely way to end it.
Thank you, guys. Appreciate it.
Thanks, Dave.
Right.
Thanks,
Cheers,
Steve.
Charlie.
Cheers, guys. Bye. Bye.